That, dear colleagues, it's my great pleasure to introduce our next speaker, Professor Daniel Kendorf. Is Chief Physician at the Center of Orthopedics and Trauma Sport in Helios Clinic, Berlin, and Director of Endo Clinic in Berlin. We are honored to have him with us today to share his insights on modularity using BioBall system in revision hip arthroplasty. Please join me in welcome Professor Daniel Kendorf.
Thank you. Thank you, Carlos. Thank you for the kind invitation. Can you hear me well? Okay, so thanks. I followed your congress, but not so easy because my Portuguese is not that good, obviously. So obviously I will talk in English and I will try to talk slow and show you my slides with this. And please let me know. I think we have enough time for discussions right after the talk. Just 1 second. Can you see this now? Please give me a sign because I cannot see you anymore.
Yes.
Okay, thank you. Great. So thanks for the great invitation. And I wish I could have been there, but I'm quite sure because of the weather, even if I would like to fly to Portugal right now, it's almost impossible from Germany. But never mind, I think for a short talk, it's also nice to discuss via online versions nowadays. So I'm happy to show you my experience with the Mercator system in revision THA. Actually, I give you some backsides of my personal situation and of the situation maybe in Germany and I think also in Portugal within the next years and decades. You really see that there are obviously challenges in revision THA, not only for the stem side, but also for the cup side. This has been the case for most decades because the wear usually affects earlier in the past, at least the cup side than the stem side. So the goal of revision, it's clear, and you discussed this before. We want to support the cup. We want to create a normal anatomy. We're trying to reconstruct the leg length if possible, and we want to preserve the bone stock for further revisions because after the first revision, many times, there'll be a second or third one in many cases, in many especially elderly patients. So my priority, I'm a posterior guy. I learned the posterior approach when I was in New York, and I did this also in Hamburg in Endo Clinic. I recently also started the DAA approach, but for especially for my revisions, I'm much safer and I feel safer myself using the posterior approach, to be honest. Maybe in the future also through direct anterior, but so far I have done only direct anterior approach for my primaries. So the posterior approach obviously has advantages. It's no flexion of the gluteal muscle. I got an excellent overview of the stem and the cup. And I can extend very easily to cranial and caudal if I need to. But there are also disadvantages, as you know. I am in lateral position, so the highest disadvantage of the posterior approach, especially in revisions, of course, as everybody knows, is a dislocation risk. And we know from literature it can be in revisions between 10 and 20%, sometimes even higher. And of course, because I have a lateral position, the leg length control is not always as easy as in supine position. The first case I want to show you, and this is typical for Germany because many surgeons in Germany were trained in lateral approach. Unfortunately, we used to have a series of very well fixed stems, as you see in this X-ray. We can discuss later. The problem is to remove this stem, you need to basically cut out the whole proximal femur. It's a totally ingrown, very rough surface. The problem is, if I know I'm going to revise it from posterior, I know I have a low anteversion in the stem, and I have a combined anteversion which is quite low. So this is an old technique I did for many years. As you've seen here, I used the GANS reinforcement ring, which works nowadays. I use 80%, 90% even cups like tantalum or Redapt or others. But back then, I was trained to use the GANS reinforcement ring. It works, especially if you do in combination with impaction bone grafting. However, if you leave the stem in, it became possible to correct the anteversion with the Mercator system of 7 degrees. Because remember, the stem is neutral, and I did this approach from posteriorly. Again, if I need to leave in the stem, I need to have a good plan because I don't always want to change the stem. As our friends in UK, they have the Exeter stem we don't use in Germany, so we don't take out the stem very easy. So mostly, in case the stem does need to be revised and is well fixed, I'm trying to avoid it and just reconstruct my cup, as you see here on those 2 images, which can easily fail. So we have to be prepared before we plan our surgery, especially revision surgery. Those are all officially 12-14 tapers. And I assume in Portugal you also have usually mostly 12-14 tapers nowadays. But you see the difference. They're all different. So we have to be careful what system we use in the revision case, also for medical legal reasons. So for the Mercator complete system, I'm using even 18 years now, to be honest. It's quite easy for me to identify the stem, especially if the conus is intact, and to do adjustment of the CCD and the anteversion if need to. So I'm able to control the leg length and the anteversion or offset, depending on how I adjust the offset adapter, as I will show you. So you have to be sure the taper is intact, because if the taper is not intact, you might be failing because the new ball, if it's metal or ceramic, it won't fit perfectly, and it might dislocate from the pre-used stem. So you see here some examples. So this on the left side, you see, I think this is a taper you can easily reuse. To be honest, on the right side, you have to be very careful because any of the systems that I show you might not be adjustable anymore, and it might get loose after a couple of days or even within a couple of months because the taper doesn't work anymore. So first of all, if you check your previous taper, there's a good tool on the set they can use here for 12-14 or 14-16. In my eyes, at least in Western Europe now, especially in Germany, I would say in Austria, we have 95% 12-14 tapers. But anyways, you are able to check if it's still intact, if it's deep enough, as seen here, to make sure the new head fits on perfectly. And then you are able to adjust it quite easily to the leg length that you want to see. You see here, you have to be careful to make sure the previous taper is somehow still intact. There's a good list you can get from the Mercator system in order to make sure what they offer, also for the Striker system. As you know, Striker is the only system that has not a 12-14 and is different. I'm using Striker myself, so I know I have to be careful in those revisions compared to others. And again, this is a whole portfolio, as you see here. The major advantage in my eyes, I can add up, as you see on the picture, up to 5XL in the standard variation, and I can do 5XL in the offset variation. And as I told you before, 5XL offset gives you also the possibility to rotate 360 degrees to adjust anteversion or offset, high or low offset, and of course leg length. And I give you some examples, and this is what you keep in mind when you use your Mercator offset system, because of the aconical shape of the taper. You can adjust it depending on how you put the conus, the new conus, on the old one. As you see here, on the 12 o'clock position, you adjust a higher valgus angle. If you return the 12 o'clock position 180 degrees, you get a higher varus angle. Same you can use for anteversion. And this is what I told you before. In my experience with the posterior approach, changing from anterior or lateral, I really appreciate putting more anteversion in the mostly neutral stem. And again, you see it here, how you can really change the offset and the leg length accordingly. Just showing you some easy and then different and also harder examples from our clinic. You see on the right side, Wern, polywear, the cup is not perfect, but do you want to change it in an old lady? Maybe not. So you put a new inlay there, you make a 2XL ceramic head from Merete, which makes your life very easy. Not in a standard variation, because the lateral approach has been used again. This triangular stem, as you all know, is well fixed, can be very hard to take out. Again, you can adjust it also with dual mobility, because to adjust the leg length, as seen here, dislocated, old destroyed cup, we have to use a 4XL, because to adjust the leg length and the tension on the leg. With a 28 head, because as you see here, I used a cemented dual mobility cup on this patient. Easy case, I'm still using hybrid techniques on my 75-year-olds and above, which is quite common in Germany, and it works quite well. However, the main disadvantages of the posterior approach, you see here, it can dislocate, especially in the ladies who don't have enough muscles. And then to make sure I have a relatively easy revision without changing the cup, because if you look at the cup, the anteversion is fine and worked well at the other side. So we just used an offset Merete system in combination with a new inlay with a posterior hooded inlay. So this was solved quite easily and can be a quite quick surgery, especially for the elderly and sick patients, if you need to do so. We're getting more complex on patients like this. The stem is in for 30 years. This has been a tumor case previously. And as you have also discussed in your talks today, sometimes, not very often, maybe 10 times per year, I'm using a custom-made implant, as you see on the right side. In order to use it, you have to use a Merete system to adjust length and offset to adjust the stem, which is very well fixed and you don't want to take it out. And other case, older cup got loose, put in tantalum cup in combination with the old triangular stem. You don't want to change it. You change the leg length and offset with the primary Merete system as seen here. So not that hard. Getting a little bit harder in those cases, you see the very high offset that you need. This is not dislocated, as you know. This is a high offset inlay with 20 degrees and an elevated liner that even needed still to get the tension, needed a very high offset neck leg length ratio. You've seen here other cases. My clinic is in Eastern Germany, eastern part of Berlin. There are sometimes prostheses which are not available anymore. You see this high offset adapter already in there, the broken Boy Schneider cage. I decided to stay in this high hip offset because she has been in high hip for 25 years, even longer. So again, to make order to be able to adjust the offset and leg length, I used, in addition to the old adapter, a second adapter to get the high offset so she wouldn't dislocate. Again, this lady had no muscle at all. Her gluteal muscle was all gone because she has been a tumor case 30 years ago. Remember, when you do cases like this, there's always a good power in the system, and I'll show you what I mean. So tantalum used in a severe protrusion of the pelvis after a car accident. I think the post-op X-ray looks okay. I used a cementless stem on the other side, but in combination with a dual mobility cup. You see the dual mobility cup, if you look closely inside the tantalum bigger cup. And what I mean is like this, which happened to me fortunately only once. You can still dislocate the stem if it's not grown in yet. So sometimes you have to be careful of how much tension and how much force you put in your system. This is what I mean when I say there's a high system on the system itself, high power, as you see here. And again, just to make sure it won't dislocate again, and it was a young patient, I decided to cement the stem in the next phase, which of course worked as well. Other cases, again, infected, which I do roughly 100 infected cases a year, hips and knees. So we do, if possible, a one stage, but however, not always possible. We did this two stage because a troche came off when we took out this Sportorno stem, as you see here. We had to wire it in order to allow a good stability of the bone. We put in stimulant beads for local antibiotics in combination with a spacer, as you see here. And then afterwards, we put a monoblock stem in after she was healed. But also, we needed a high tension because the gluteal muscle was somehow damaged, as you see here. We had to use a tantalum wedge in combination with a dual mobility cup. It's a quite easy and I would say reliable option. However, the tension was still not high enough, so we had to use a Merata system to get to a 3XL in combination to allow for high tension of this patient. Again, they're able to dislocate, and if they dislocate, you might be able to increase the tension without changing the whole system, as you see here, by using a Merate offset and leg length adapter, as seen here. It might be a good solution, might not be. You can also change the whole cup if you need, but this is a quick solution, especially for the elderly ladies, in case the operative time needs to be low. So in summary, isolated cup revision is not really rare. The stem system should be known to make safe the surgery planning. You can control the taper with a system of Merata. You can correct the leg length up to 5XL, which is very unique. You can correct the anteversion up to 7 degrees, and there are metal versus ceramic option. So in clinically, and again, I've been using it since almost 18 years now. It's a very reliable system. And so far, bless God, I haven't seen any failures, any breakage, not even of those 4 or 5XL extensions. Thank you very much. Obrigado, as you say in Portuguese, and I think we have maybe some time for discussions. Obrigado.
Yes, thank you. Some questions from the table? Yeah, Dr. Eurico. It's on.
Good morning, Professor Kendorf. Thank you for your presentation. There are two questions that rose in my mind when you were talking. We often don't like modularity, so this is one interface more. Since you're using it for more than 15 years, I would like to ask you, have you ever had... Anything. Oh, sorry. Are you hearing me now?
Now, yes.
Okay, so I'll phrase again. It's one more interface, it's modular. So the question I would like to ask you is, have you ever seen in your experience problems with corrosion or failure of the system?
That's a very good question, and I think this is also the most important legal question. Actually, I have not, because the sleeve on sleeve, people were in the past very afraid of high corrosion. And I have not seen it, and I also have revised them for obvious reasons. Sometimes they dislocated, sometimes they were infected again, and I have never seen more than normal corrosion. And I think, and we can probably ask the company, it's probably based on the component material that they use.
Thank you.
And again, in Germany, mostly there are titanium sleeves. So it's not so problematic.
Okay, the other question I would like to ask you is the neck becomes more thick. So this reduces the range of movement, of motion. So do you think that poses any issues about dislocation?
This is a very good question. I think in a normal cup, no big issues. I've seen this. It can lead to wear of the poly, especially when you have seen some cases when I used it with dual mobility. So sometimes it impinges earlier when you flex it deep or externally rotate it too deep. So it's always, let's say, in between situation to adjust tension and provide a stable hip. So you have to really adjust it. So sometimes even what I did is I put in the trial of the adapter, and then I readjusted it a little bit more to make sure it doesn't impinge in too deep flexion, for instance. So you really have to be careful. But the good thing is if you have a high offset adapter, you're getting quite far away from the inlay and or from the metal of the dual mobility cup.
Thank you.
Any more questions? Okay, Professor, thank you very much for your presence here. It was a pleasure. I think we're gonna continue with some other thematics, and I hope you can still watch us in the event. Thank you.
Thank you. Obrigado.